In this video, we're going to be talking about spinal injuries. The spinal cord is made up of nerves and nerve cells that communicate messages between the brain and the rest of the body. The spinal cord is protected by the spinal column, which is made up of 5 sections: the cervical, thoracic, and lumbar sections, as well as the sacrum and the coccyx. Each vertebra consists of 2 major parts: the body on the anterior side and the arch on the posterior side. This structure allows for mobility while protecting the spinal cord, which runs through an opening called the foramen. In between each vertebral body, there are discs that add padding and help to provide space for spinal nerves to stem out from the spinal column through openings in the vertebrae. The spinal cord and the nerves stemming from it communicate all temperature, sensation, and motor signals between the brain and the rest of the body. Each pair of nerves leaving the spinal column innervates a specific region of the body called a dermatome. So, when you look at the pair of C8 spinal nerves exiting between the C7 and T1 vertebrae, you can see that it innervates the region covering the lateral aspect of the arms. We can use this information to help determine how high up the spinal cord an injury might have occurred. Per protocol, when conducting a spinal assessment, we check for motor and sensory deficit on specific dermatomes using the nexus exam. Check out our video on spinal assessments for more information on how to conduct a spinal assessment or the nexus exam. When we look at spinal injuries, it's a very big deal because these have the potential to affect a patient for the rest of their life. Spinal cord injuries are likely going to be irreversible. So it's very important that we as providers in the pre-hospital care setting are able to recognize spinal injuries and evaluate the different mechanisms of injuries so that we can determine whether or not spinal precautions need to be taken. This is especially important in the cervical spine because the higher up the injury, the more profound the deficits may be and the greater the threat to the patient's life. Cervical spine trauma is the most common type of spine trauma and makes up more than half of all traumatic spinal injuries. It's also important to remember that there are some blood vessels that transverse through the cervical vertebrae. If there's any damage to the cervical bones, it's likely that there's also going to be a vascular injury. Because roughly 20% of the blood that goes to the brain comes through these arteries, if those arteries are injured, it's likely that the patient will also experience some altered mental status, irregular pupils, changes in vision, or even some stroke-like symptoms. So all of these need to be kept in mind that they are potential signs for spinal cord injury. Another important sign to look out for patients that were in vehicle accidents is the seatbelt sign. This sign indicates that the patient had a fairly high impact mechanism to the neck and spinal precautions should be taken. Always keep in mind that the diaphragm is controlled by the C3, 4, and 5 spinal nerves, so any injury to the upper neck can result in breathing problems that necessitate airway management. When talking about spinal injuries, we typically think about spinal cord injuries. However, spinal injuries could also include any injuries to the vertebral bones, the discs, the ligaments, or the muscles surrounding the bones. It's important to remember that even if there are no neurological deficits or pain, there could still be injury to the back that requires that steps be taken in order to protect the spinal cord. Burst discs and compressed vertebrae can put pressure on the spinal nerves, leading to motor or sensory deficits. Fractured vertebrae can expose the spinal cord to injury or lesions, and torn ligaments can make the spinal column unstable, leading to potentially disassociation or separation, and excessive forces can shear the spinal cord. With a C1 or Jefferson burst fracture, which is common in vehicle accidents from the head hitting the windshield, a rollover, or other accidents like diving, these patients may only have neck pain and no other deficits. In elderly patients that have experienced low-impact falls or patients that have hyperextended or hyperflexed their neck, they may have an odontoid or C2 fracture. With these fractures, there may be no pain or deficits, but the stability of the neck could be compromised since this is the bone that allows our heads to rotate and ligaments on the odontoid help to connect the spine to the head. Excessive amounts of lateral force on the head and neck can cause an atlanto-occipital dissociation. This is the tearing of the ligaments connecting the skull to the spine, leaving the patient's spinal integrity very unstable. These injuries may not have any obvious signs of neurological deficit initially, but only about 30% of these patients will survive. So it's up to us to evaluate the mechanism of injury and determine whether or not the potential for spinal injury exists. Mechanisms with the potential for causing spinal injury include hyperextension or excessive posterior movement, hyperflexion or extensive anterior movement, compression, like from a fall, rotation about the vertical axis, lateral or sideways stress, and distraction, which is excessive stretching. These mechanisms can result in injury to the spinal column and damage to the spinal cord. If any of these mechanisms exist, refer to the Spinal Injury Assessment Protocol on how to proceed. Furthermore, we need to take particular care with geriatric patients. As we age, our bones become more brittle and more susceptible to damage. Even a benign mechanism, like a fall from standing or a fall from a chair, can result in spinal injury. Remember, even if there is no pain or neurological deficit, the potential for spinal injury still exists. That is why our protocol says for patients over the age of 65 with the mechanism with the potential for causing spinal injury, we should still place a C-collar even if the clinical assessment is negative. Lastly, if a patient has experienced spinal trauma, keep an eye out for signs of neurogenic shock. This is a distributive form of shock caused by a spinal cord injury resulting in the sympathetic nervous system losing its ability to communicate its nerve impulses with the rest of the body. This will present with bradycardia, hypotension, core hypothermia with warm, dry extremities, and possibly be associated with paralysis and difficulty breathing. Similar to other forms of shock, these patients are not adequately perfusing their tissue and their organs, and these should be considered to be priority patients. Ensure that you're actively managing their airway, providing oxygen and ventilation as needed, keeping the patient warm, and requesting immediate transport. For additional information about spinal injury assessment or taking spinal precautions, see your protocols. If you have any questions, please reach out to a member of the EMS training team.